How to guide hypotensive therapy? Well, I think it's appropriate to talk about your conflicts of interest, and these are my important conflicts of interest. That's my wife, Janice, and my 3 children. These are my unimportant conflicts of interest. I'm a consultant to every known hemodynamic monitoring company except for 1 or 2 that I just saw, and I'll be talking to them later today. Hypotension is a medical emergency. Okay. It must reduce blood flow to the heart and the brain. It does cause ischemic injury to the organs, and the organs that will be caused to be ischemic in terms of time are first the kidney, the gut, and the liver. And if I am hypotensive, I abolish the autoregulation of blood flow amongst tissue, because the only way I can increase blood flow to one organ when it's metabolically more active is by having it have local vasodilation. And that local vasodilation won't cause an increase in blood flow if there's no driving pressure to allow that flow to occur. So I do not have to invent septic shock to lose autoregulation of blood flow. All I need is hypotension, and I can't autoregulate blood flow at all. It induces a strong sympathetic response, causing ACTH-mediated release of cortisone and endorphins. Cardiac output within this context is only important to maintain an adequate pressure. And thus, in the setting of hypotension, one has an inadequate cardiac output by definition. Now, the etiologies are different. In 3 of the 4 primary etiologies, hypovolemia, pump failure, and obstruction, there is a low cardiac output, whereas in vasomotor paralysis that Benoit Vallée is blocking by his head, you have sepsis. They all cause hypotension, but you will agree with me that the management of each one of these is quite different. And thus the monitoring and the management of these patients will be different amongst them. The physical findings of shock are impressive but non-specific. They include everything. More importantly, almost all will have tachycardia unless there's beta blockade. And occasionally in elderly people you won't see much tachycardia, but it's a relative tachycardia. And importantly, hypotension occurs late. Though I was asked to how do you treat the hypotensive patient, I agree with other people who talked before yesterday that hypotension is a late expression of circulatory insufficiency. And when it does occur, it already means that you've got organ ischemia. How should I look at it? Well, one of the groups that I know, John Kellum and Lou Kaplan, were in Philadelphia, and they looked at trauma patients coming into the emergency department, and they just looked at the relationship between the strong ion gap, which is an accurate measure of intercellular metabolic acidosis. You just have to measure a few electrolytes and protein. It can be calculated on an Excel spreadsheet. It's not a big deal. And they were able to show that it was better than the injury severity score in trauma patients in the emergency room of predicting who will die. And furthermore, it was better than lactate. And we know that trauma surgeons like to use lactate as a measure of ischemia in their patients in the trauma bay to figure out who's going to be sick and die. And this paper, which you can't see because Benoit Vallée, again's head is in the middle of it, is from Critical Care Medicine, volume 32. Okay, volume 32, 2004. And as you can see, lactate is not that good. pH is close to useless. And the pH is close to useless because the patients could be hyperventilated if they're intubated as well. So the treatment priorities are shown on this slide here. You want to restore the mean arterial pressure to greater than 60 or 15 millimeters less than the baseline of a previously hypertensive patient. And that's just a start. It may well be that in the patient it needs to be higher. But it has to be done independent of cardiac output, because if you don't have a perfusion pressure, you can't perfuse the heart and the brain. You want to give fluid restoration if you have hypovolemia in a fluid-responsive patient until you have adequate organ perfusion. Now, how you determine adequate organ perfusion is going to be an interesting debate that we have for several years to come. I personally like to see urine output going up. And if it's an acute shock and I can rapidly resuscitate, I will see that. But if you have an organ injury, I might not see it. Jean-Louis and I have mentioned an SVO2, mixed venous O2 sat of 70%. A central venous O2 sat might be useful if it's low and comes up. Lactate clearance is always good. Veno-arterial CO2 difference less than 6. improving sensorium and loss of tachycardia, and in specific populations, as we heard yesterday, targeting an oxygen delivery, which would need, therefore, an accurate measure of blood flow to 600 mLs per minute per meter squared would be useful. I was just at a trauma symposium in Pittsburgh where it was stated that if you have a single hypotensive episode in a trauma patient, it quadruples the mortality of that patient. So if a patient comes in with trauma and during the time in they had no hypotensive episode, even if it lasts for a minute or less, just having one episode of hypotension quadruples mortality. Now, what are not priorities? Aiming for a 65 millimeter blood pressure in a previously non-hypertensive patient. There's no reason to make the blood pressure higher if you're in fact having good function in the patient, but it needs to be individualized. Aiming for a minimal CVP or pulmonary artery occlusion pressure, even in septic shock. I disagree with the surviving sepsis guidelines on targeted CVP and pulmonary artery occlusion pressure, and I believe most of the people in this room agree with me on that point. Aiming for a minimal cardiac value, I think, is a ridiculous target. You need to have a cardiac output that's adequate. There is no number I'm shooting for. That is, unless I am specifically coupling it to a goal-directed therapy and a specific population in which it's been shown to improve outcome. In general, I just want to have a hard enough cardiac output to maintain organ blood flow and good pressure and see adequate organ perfusion. And I don't know what that cardiac output is in a given patient. Okay. We do know, and I'm going to say this briefly simply to document it, that early goal-directed therapy, pre-optimization, and post-optimization studies have all shown improved outcome in various techniques when used in targeted specific patients, high-risk surgery, post-op patients, and sepsis, at least in Manny Rivers' hands in Detroit. And so the point of the matter is that these things are very important, but they aren't the most common patients that we see in the ICU. If you were to measure the arterial pressure relationship versus aortic flow in a human being, and I showed you this data 2 days ago, you will see that there is a pressure and a flow relationship. And if I simply do an inferior vena cava occlusion in a human being, causing the aortic flow to decrease beat by beat, I see the pulse pressure decreasing beat by beat. And this means that I can define the pressure-flow relationship. And this is the importance of why cardiac output is important to maintain blood pressure. If I want to increase blood pressure, I have to increase flow. And I can talk about the relationship between the change in pressure to the change in flow is the tone of the arterial vasculature. And of course, I mentioned before that in you and I, we have a zero flow pressure of about 40 millimeters of mercury, which is the effective back pressure to the arterial flow. Within this context, though, an increase in resistance would mean that for the same increase in flow, I would get a much higher increase in pressure. And that's wonderful because in obstructive cardiogenic and hypovolemic shock, we have increased tone. And I don't need to have the cardiac output go up very much to have an increase in blood pressure. Whereas in septic shock, I have a decreased tone, and I have to increase the cardiac output a lot in septic shock for blood pressure to go up. That is the rationale for giving a vasopressor in a patient in septic shock, because I can't maintain organ perfusion pressure just by giving fluid alone if I have loss of vasomotor tone. What's important acutely is to look at the difference between the kidney, the gut, and the liver in terms of their pressure-flow relationships. And as you can see, there is great increases in gut blood flow. I'm sorry, it's too early in the morning. Kidney blood flow versus liver blood flow with changes in pressure. So, if I have a given mean arterial pressure and all I do is have an episode of hypotension by decreasing the mean arterial pressure, as you can see, I will get a much greater decrease in renal blood flow than gut blood flow and then liver blood flow. This means that in your patient, acute hypotension is going to cause an immediate renal ischemia, whereas the liver will be relatively protected. And you know this is true because you've seen hypotensive patients that come in and they're in acute renal failure, but their liver is working just fine. So organs will have a differential response to hypotension. This is a study that the late Dr. Schlichting did in our laboratory in which we hemorrhaged animals down to 10 and 15 mLs of bleeding. And you can see that the mean arterial pressure went from about 100 to 50. But what I wanted to show you is if you look at the renal flow, the scale is 0 to 110, 210 on the first point, but by the first bleed, the flow is next to nothing in the kidney, whereas the portal vein and hepatic arteries flow, though down, is only down by 1/3. The kidney just loses blood flow immediately. And you probably have seen these data before. If you artificially increase mean arterial pressure using norepinephrine to values of 75 or 85, you don't increase organ perfusion by measures that we look at to determine tissue viability. So the key points here are normal autonomic adaptive mechanisms tend to preserve, and they really may increase it, I can see that here, arterial pressure in the setting of decreasing blood flow. And thus, hypotension is a late manifestation of circulatory shock. Hypotension must be associated with tissue hypoperfusion. And you then target a mean arterial pressure of 60 or higher, and people are saying 65, and that's fine with me. And then you address blood flow. So now I'm going to go over to management for a second and talk about volume responses. Why don't we give cardiac output of fluid to everybody? Because the signs of cardiovascular insufficiency are pretty impressive but nonspecific, and most people have a decrease in their effective circulating blood volume. Well, as you've seen from Frederic Macquart and Jean-Louis Touboul in their meta-analysis of responders and non-responders, and actually Jean-Louis Vincent and I are authors in a couple of these papers, fully 50% of the patients who are presenting in hypotensive shock will not increase their cardiac output when given fluid alone, and therefore you're not treating them properly. And as you saw from the Kumar paper, there is no relationship between CVP and end-diastolic volume of the right ventricle, or wedge pressure and end-diastolic volume of the left ventricle, or between changes in CVP and wedge pressure and stroke volume. So if you've learned nothing else from the last 3 days about hemodynamic monitoring, learn this. Preload is not preload responsiveness. I can have a big ventricle and be volume responsive. I can have a small ventricle and not be volume responsive because of diastolic dysfunction. So knowing a wedge pressure or CVP, though telling me volemia, it tells me that there's volume in the body. It does not tell me if my patient is volume responsive. Starlings' law of the heart still works, however, because if you do increase the end diastolic volume, stroke volume will go up, but you just have no idea in a patient when looking at it at a single point in time if that will happen. So we asked 3 fundamental questions in our patient in shock. Will cardiac output increase with fluid resuscitation? And if so, by how much? That is the volume responsiveness question. The second one is arterial tone increased, decreased, or normal? And the third is, will the heart maintain blood flow under pressure without going into failure? You might ask other questions of your patients, but I submit to you those are the 3 fundamental questions that you ask of all your patients. When you look at the effects of positive pressure breathing, and this is a study by André Deneau from our group, this is a human being, and we measured left ventricular area, you can see clearly that during positive pressure breathing, end diastolic volume, which is the largest part of this area, goes down with breathing. So you can use that to look at stroke volume variation, and I know you've seen this slide before. If you have a normal or a sick heart and you're underfilled, you'll see stroke volume variations because the obligatory changes in filling. Whereas when you fill up more, the sick heart will no longer give a response. You'll still see stroke volume variation in a normal heart, and eventually when all hearts are filled, you're going to see no stroke volume variation at all. And then based on this, the logic comes that you can look at the pulse pressure variation to follow stroke volume. As I showed you, we showed in human beings that there's a tight linear correlation during instantaneous changes in flow between pulse pressure and stroke volume. And so the number of papers that have been published in the peer-reviewed literature as of October 24th, 2009 was 112. I don't think I need to defend that pulse pressure and stroke volume variation predict volume responsiveness. It shouldn't even be studied anymore. We should simply be using it to treat patients. You can't use it, of course, in atrial fibrillation, and you can't use it in spontaneously breathing people because atrial fibrillation changes the filling time, and spontaneously breathing people with diastolic interdependence alters diastolic compliance, and that's cheating. And so what Xavier Monet did in his study with Jean-Louis Touboul is they simply did a passive leg raising, but you could give a volume challenge too. It doesn't matter, but this is reversible. And if you had an increase in cardiac output, here shown we're using the Hemasonic, not the Deltex esophageal Doppler, but I submit you'd probably see similar data with the Deltex as well, you had an increase in cardiac output. And it wasn't special to these esophageal Dopplers. As you can see, that there was an increase in flow with leg raising. There was an increase in cardiac output. We did the same thing using a new device, the Cheetah's NICOM device. But I bet we would see the same thing with the LIDCO or the PICO or the FlowTrack if we monitored it continuously too. This is the concept of using these devices functionally to determine volume responsiveness. So with, there he is, with Daniel DeBacker, we propose that in a hypotensive patient who's spontaneously breathing, to assess preload responsiveness, a fluid challenge is totally appropriate. But you can do passive leg raising as well. And since, if we consider now arterial tone, mean arterial pressure and stroke volume are going to give you a constant point. But if you were to double your stroke volume, you wouldn't double your mean arterial pressure. And if you had a dropped beat, the blood pressure at that point in time that would fall to would not be zero. It'd be some positive value. And the slope of that line is called arterial elastance. And if I have, for the same stroke volume, a decrease in blood pressure, I have a decrease in arterial elastance. And if I have, for the same stroke volume, an increase in blood pressure, I have an increase in arterial elastance. And this isn't physiology, this is physics. This has to be true. This is how we define things. And thus, based on this alone, if I simply look at the dynamic changes between mean arterial pressure and stroke volume in my patient, I know exactly if their tone is going up or going down. And so I can say if I see an increase in stroke volume and mean arterial pressure, this is what I'd expect to see with volume loading, exercise, and increased catecholamines, which may include pain. And if I see them both falling, that's shock, hypovolemic, cardiogenic, and obstructive. But if I have an increase in blood pressure and a fall in cardiac output, that's what I expect to see with an increase in vasomotor tone, as I'd expect with vasopressor therapy. And finally, if the cardiac output goes up but the blood pressure falls, this must represent vasodilation, and that's what I expect to see with sepsis and vasodilator therapy. So based on that, we can suggest the following treatment algorithm that requires hemodynamic monitoring. Is my patient hemodynamically stable? And that's a hard question to answer. But if the answer is yes, don't do anything. But if they're not, then you ask, are they volume responsive? Yes or no. The threshold value of 10 or 13% of pulse pressure or flow, it's immaterial to me, but that's the concept. But you don't stop there. You say, is my patient also hypotensive and have decreased vasomotor tone? And the answer is yes or no. Well, if he's preload responsive, that's half the patients that Frederick Makar and Jean-Louis Thibault described. That's half the population. But if they're also hypotensive with decreased vasomotor tone, then increasing cardiac output by giving volume would occur, but the blood pressure wouldn't go up. That person needs not only volume, but a vasopressor. Whereas if they're preload responsive, they could still be hypotensive, but they're vasoconstricted. All they need is volume. But let's go through it. What about if they're not volume responsive? Do they have hypotension, decreased vasomotor tone? Yes or no? If their vasomotor tone is decreased, that would be like a septic shock patient who you fluid resuscitated, but they're still hypotensive. That person needs a vasopressor. And if they're not stable, they're not volume responsive, and they may be hypotensive, but they don't have decreased vasomotor tone, the problem is between my two hands. I don't know what the problem is, but it's right here. And this person would need an echocardiogram, but while I'm getting the echo machine, I would be starting a dobutamine infusion, and I could repeat and cycle this just fine. And this is a very straightforward approach to the management of patients. Thank you very much for your attention.